the DD Access Supervisor for Network 180. So I work in the Access Center. So I want to just give you an overview of community mental health and accessing services and eligibility criteria for adults with developmental disabilities. Network 180 several years ago was Kent County Community Mental Health, or Kent CMH. So the state has a Department of Community Mental Health, and they funnel down Medicaid dollars for mental health services to all the counties. Some counties, like Kent, are large enough to stand alone. Other counties that are smaller have affiliated and joined together with a few other counties to make a community mental health. And so community mental health is the public mental health system, and we receive Medicaid dollars from the state of Michigan through their Department of Community Health. So it is a governmental agency, it's a mental health authority, and we meet the needs for mental health services for people with Medicaid or indigent persons in the community. Okay, it's not advancing. Okay. So we have a contract with the Michigan Department of Community Health to provide services for adults with mental illness, for children with emotional impairments, developmental disabilities, and their families, so all types of children, or all types of mental health issues for children, individuals with substance use, and adults with developmental disabilities. So we have a contract to provide all those services. So, as I said, we receive Medicaid funds from the state each month, and the Medicaid dollars we receive are based on how many Medicaid eligibles we have in the community in Kent County for the month. And so that's how we receive our funding. And by law, Medicaid is the payer of last resort. So if you have other insurance or Medicare, all those insurances are typically billed first when you go to receive physical health services in the community. Some of mental health services as well, like Medicare, will be billed first, and Medicaid is the payer of last resort, which means that we have to make sure that all community resources have been explored. If there's other agencies in the community that could meet the need that you present with, we have to make sure that that is, you look at that place first and get your needs met through them before mental health will provide the Medicaid dollars to us to do the service. And it just gives example, like mandatory ed, and I'll get into that later. Michigan Rehab Services, which provides vocational services for people with disabilities. They would have to be tapped into first before you can come to mental health for those services. And what guides us is the Medicaid Provider Manual. It's very thick, so I'd like to go to just certain sections. And it talks about what's covered in terms of Medicaid benefits. And it talks about those services, talks about eligibility and medical necessity, which in the mental health world is clinical necessity for a service. So if you ever want to go to that provider manual, you can find it under michigan.gov. I'm going to talk a little bit about adults with developmental disabilities, what type of services might be available to someone if they meet eligibility. And then I'll talk about eligibility a little bit later. So supports coordination. Supports coordination is similar to case management. You may have heard that term before, where you get someone assigned to you to do the functions, and it reads just like this in the Medicaid manual: planning, linking, advocacy, coordination, and monitoring of the supports that are necessary for you. So that person is charged with a huge responsibility. They're very key, they're a key role, because they're the ones that are going to hold a plan of service for you, similar to like an IEP, where you identify what the needs are, what the goals are, and then they're the ones that are going to have to orchestrate this whole thing. They're going to have to make the referrals to the providers and monitor progress and monitor whether services are meeting your needs. So they'll be doing that for you. And you need to have that person in order to orchestrate the whole mental health service array for you. So they're very key. This just talks a little bit more about the clinical professional, and they will do the assessment, they'll monitor the services, etc. Supported employment is a service that can be delivered if you're eligible, that supports you to develop a job, to find a job, to assist that person once they're on the job. You've heard the term job coach before. That'd be someone that would shadow the person for a while, help them learn the task, and then do some follow-up afterwards. We have a few providers that do that for us. Hope Network is one of them, and Goodwill does that for us as well. So we have lots of providers in the community, and I'll talk about that. We're so large that we have to contract and send out requests for proposals to get our services delivered in this county, because there's many consumers, thousands. Skill building assistance is like a pre-vocational type service that you would enter into if you were eligible before you were ready for supported employment. Maybe you still had to learn some things about doing job applications, learning to stay on task, things like that. You might be eligible. If you really want to go into the vocational world, you might be eligible for this prior to going into supported employment. So you'd make that transition once you've built some skills up. Life skills is rather new. I think I'm losing track of, we go by fiscal year, starts October 1st. I think it was like 2011 maybe, life skills was introduced. Because what we found is community living supports is a type of service that reads in the Medicaid manual, like guiding, assisting, training someone to build skills. And life skills can be delivered in a number of different ways, or the CLS can be delivered in a number of different ways. Life skills is for people that are not really interested in developing their vocational skills. Maybe they're older, they want to head toward retirement, they're not really interested in developing that. Their primary interest is they need to have some meaningful activity in the community, they want to integrate more, they want to build some of their social skills because they have some issues with that. So they might be eligible for life skills instead of the skill building or supported employment. Then there's respite services. Respite services is a service that's delivered to an unpaid primary caregiver. It's delivered technically to the individual with a developmental disability, but it relieves the unpaid caregiver from the responsibilities they have day to day. It's periodic, it's intermittent. There's many different kinds of Medicaid respite. We have some staff that are trained based on Medicaid standards to go into the home and provide respite there, so you could leave. We have monies that you can use for camp settings as long as they're licensed, like Indian Trails, you can use it there. And then there are some foster care homes in the community that will do either a drop-in or overnight respite if you just want it for a few hours. I know Indian Trails does that as well, just a drop-in thing on the weekend. So there's all different kinds of respite you might be eligible for. So community living supports, I talked a little bit about in the life skills program. We have a few providers that deliver that, like Hope does, Thresholds does, and MOCA provides life skills program. But CLS, all the providers provide community living supports. And again, it's to support, train, guide you to build skills. We want you to be as independent as possible. We want you to learn skills like meal planning, how to go to the doctors, and they might send a CLS worker with you to listen to what's being explained to you so that they can help you understand what your condition is, what kind of medications you're taking. You might need them for medication setup and administration. You might need them to help you learn how to clean your home appropriately, all the different steps and the sequencing of steps. There's also in the community, they wanted to teach you how to make friends in the community, or go into a store, make the purchase of a meal that you want to start from scratch and use a recipe. You want to buy the right items. You want to do it in the best cost-effective manner. They will show you all those type of skills. And this is less than 24 hours per day in the community. If it's 24 hours a day, then they consider it a licensed setting, but it can be delivered less than that, based on need. And it talks about unless individuals share staff or share living arrangements. So like if you live in an apartment, you have a roommate, have a couple roommates, and all of you get CLS, you can share that staff, but the cumulative hours, may be close to the 24, but it shouldn't be right at 24. There's other settings that you can have community living supports delivered in. The foster care homes in the community, we have a community placement program which provides extra funding to these AFC homes, like a per diem every day, in addition to the regular SSI or Social Security they get. It's for people with a little bit higher needs, like behavioral, medical needs, personal care needs. Those homes, though, in our community have to have a special certification. They're just not a standard adult foster care homes. They have to have this special certification. If they do, and they can meet the needs of the person, then they might be able to get this additional CLS funding in the home. And again, all that is coordinated by your supports coordinator. They're the ones that have to figure out what is your need, how much do you need in each area, how much do you really want to work on, and how much can the provider really deliver to you. If they've got 6 other people in their home or 5 other people, they're not going to be working with you probably 24 hours to build skill. We have to be reasonable and prudent with how much we're authorizing for people to work on. Plus, you don't want to work on building skills 24 hours a day. And I mentioned the Life Skills Program, which focuses on community integration and socialization. They're not in the vocational mode when they want to go into this program. Community living supports can also be delivered in a person's home, or if they have an apartment. Again, it's the supports coordinator that helps you walk through that. They figure out how many units of service the person might be eligible for. Some of those, or most of those, are going to be done through an arrangement through self-determination, actually. And there's a number of different ways to do the CLS through self-determination. It can be, you can use a provider, CLS provider, like HOPE's CLS workers. You could use them. Or you could use a private agency in the community that's not a provider panel. Like you could use Alternative Pathways, for example, to provide your CLS services. We have some home health agencies that are doing CLS services. Or you could be your own employer and hire your own staff to provide that service if you're eligible. So if you have a neighbor that works real well with your son or daughter, you could hire that person to deliver the CLS. But they will have to meet all the Medicaid standards. They'll have to have the trainings that are required. And in those situations, you use a fiscal intermediary, which is a CPA person, because we cannot give Medicaid dollars directly to you or your loved one. We have to send it through the CPA, who will pay your employee that you hired, or will pay the agency. So it sounds pretty complicated, and for the most part it is, but hopefully the supports coordinator can walk you through all of that. But you don't have to do, that's if you want to be real creative and have a lot more power with the services that you're receiving. Otherwise, you can go with traditional services. In this case, you could use, we consider it self-determination, but you could use HOPEs or thresholds CLS workers, and then you wouldn't be that involved in coordinating that. but your loved one would still receive the services. So, and then I'm talking a little bit here about residential treatment homes. We have a provider panel, as I explained, like Hope, Thresholds, MOCA, Spectrum, Community Services. They have residential treatment homes that can handle people that have a little bit higher need in residential services with their CLS services, things like medical, a lot of medical needs, a lot of physical care, personal care, some behavioral issues that they need a behavior support plan that's delivered consistently, and the home is very structured. So this is a little bit more intense level of CLS. We have, through the past several years, been able to access some homes in the community that have been able to provide a little bit higher need as well. And if you are eligible for a certain amount of CLS service, that can follow you to another home in the community. For example, like David's house is a faith-based home. They can provide services for some people with medical concerns, and they've been doing that. So you can have your dollars follow you wherever you want in terms of the eligibility for CLS. So we've been, that base has been building. There's hundreds of foster care homes out there, and there's many that have, I'm not sure if there's 100, but there's many that have that specialized certification that can handle a little additional needs a person might have. So how do you access services? Well, you contact Network 180 Access Center. If you picked up one of those Guide to Service books back there, the Guide to Service explains all the mental health services in Kent County. If you picked up one of those, it'll give you the phone number. This is the phone number again. You ask, when the helpline answers, you would ask them, could I speak to someone that does intake screenings for adults with developmental disabilities? And then we have, if there's no one there to take your call at the moment, we have a special ACD line, a voicemail line that we pick up. There's 3 of us that can pick it up. I have 2 clinicians that do most of the screens, Chrissy Lung and Dennis Dowling. And they've both been at Network 180 for many years. So it's usually by appointment. So you would call, we would schedule the appointment. And our function is to determine eligibility for DD services. Does the individual meet the definition of a developmental disability? And our definition of developmental disability is taken from the Michigan Mental Health Code, which is a public act passed in Michigan in the 70s that defines a developmental disability and other type of mental health disabilities. And it's got to be attributable to a mental or physical impairment or a combination of both. So this is where you get persons that have an ASD diagnosis, persons that have an intellectual impairment, generally an IQ of less than 70, people that have cerebral palsy or other neurological type of conditions, people that have, we've taken people that have muscular dystrophy since childhood, and they have some significant impairments. So there has to be that physical mental impairment present, has to be manifested prior to age 22. So it has to occur during that developmental period, 0 to 22. Usually with intellectual deficits, you have to have that mental retardation diagnosis by age 18 usually is when that should be discovered. But for all the others, it's up to age 22. Most things are congenital or they develop at birth because of trauma. So, that has existed, their disability has existed for a long time. And it's likely to continue. And it results in, this is the other part of that definition, physical mental disorder, and then 3 of 7 areas of functionality that have to be substantially impaired. And that's where it gets a little subjective, although we have tried to be consistent with how we approach that. We, we meet regularly, we review cases if there's some question, but there's 7 areas that we look at. There are self-care, mobility, language, receptive expressive language, learning, self-direction, capacity for independent living, and economic self-sufficiency. So really the disability and the need for support in these areas has to be substantial and extraordinary. For example, someone with mobility issues, maybe they have a wheelchair, but they're able to propel it by themselves, they can transfer by themselves, they can basically move around the community, move around in their home without any assistance. That person wouldn't get that mobility impairment right now, so it has to be pretty significant. Self-care, if you just prompt them once in a while, or every day even, just a prompt to take a shower, that's not going to rise to the substantial area. It's got to be some extraordinary type assistance, and maybe all you do is prompting, but you have to stand there with them and make them sequentially go through the task. And that's pretty significant, because most 18-year-olds, you don't have to stand there and tell them, okay, now put your arm through the armhole or whatever. Maybe they can physically do it, but you know, they need these pretty extensive supports through your prompting. That one we might say is pretty substantial. So you have to at least have 3 of those areas that are substantial in order to get services.
Excuse me, could you repeat those 7?
Sure. I have so many of these PowerPoints and I didn't have it on this one. Self-care, receptive expressive language, learning, mobility, self-direction, capacity for independent living, economic self-sufficiency. So once a person has been determined to meet the definition of developmental disability, the next step is to assess and determine medical necessity. Medical necessity in the Medicaid Provider Manual is described as, you know, something that's clinically or medically needed, that it's cost effective, that there aren't alternatives in the community. So we have to look at all that. We look at basically what's called net need. Do you have other supports in the community that can provide this to you? If you don't, then that's a need that we need to address. And if we can find some need in there, then at the access center point, we're going to say that you're eligible as a person with a developmental disability, and then you'll be able to choose a provider. But when we make that DD eligibility determination, it's all dependent on documentation that exists already. And this is a stickler sometimes with cases, but we have to already have documented proof of the disability. So we get that from the school system. Sometimes has the IEPs and they do psychological testing. If you have an intellectual impairment, we can use that as part of our documentation that gives us that disability. The doctors, if they see neurologists, you know, psychiatrists for like autism spectrum disorder, we have to have some documentation from a physician, you know, a psychiatrist. For intellectual disabilities, it has to be psychological testing that was performed and shows that that IQ is 70 or below. In some cases, and it's preferred that they do adaptive testing as well that shows that you're impaired. Not all people are doing that, but in the future, I think we're going to see more of that. So we have to collect all this evidence. So what we'll ask you to do is either bring it with you, if you need us to send you a release so you can sign it, so we can try to access it from the school, we'll do that as well. But we're under some pretty strict timelines with Department of Community Health. By the time we take your referral call, we have to schedule an intake appointment. In most cases, we have to schedule it within 14 days. So we have to get all this information pretty quickly. Either you bring it with you or we get those releases sent out real quick and try to secure that documentation, because that's the only way we can pass the case along to a provider. And from the point of the intake screening, we have 14 days for you to see your provider face-to-face. So there's all these timelines, and we have to send them all this data about how quick we're turning all this around. So if you are determined eligible, then we will try, in most cases, to schedule an appointment with you with the provider you selected. So by the time you leave, you should have an appointment to see them within those 14 days. So again, if you are determined eligible for services, a provider is to be selected by the, we call them consumers, they've been called client, there's just lots of different names. The person and his guardian, or his guardian. They have to select a provider, and the provider will assign a supports coordinator. So the provider you select has a number of supports coordinators on staff, and they'll assign you a support coordinator. And then they'll work on determining medical necessity for all the other services. That service array that I showed you, support employment, whatever. They'll see what else, how your needs are, how they play out, and what services you should be referred to.
Is that the person-centered plan? Is that what you're
Right.
referring
They
to?
do it through a person-centered planning is the process, person first. The plan of service is called an IPOS, Individual Plan of Service, IPOS. And that's like similar to that IEP. You identify strengths, needs, then you identify some goal areas, and you make the appropriate referrals to meet the goals. So the supports coordinator does a comprehensive review. They do an assessment, and they summarize the needs in an assessment and also in that individual plan of service. So as much as possible, they want services to be delivered in an integrated setting, and that's in the Michigan Mental Health Code, and they want things to be the least restrictive environment. Some people, have a lot of, they have some behavioral issues that they need a support plan, but our hope would be that they don't always need that level of support, that they could move to a least restrictive setting. Maybe someday they can live with a friend in an apartment and get that CLS right in that apartment that they're living.
One question, is Medicaid a requirement to approach the access center?
Medicaid, we do allow people to enter without Medicaid, but we usually do a 4-month authorization to see if that person can get Medicaid. So if they've not applied, that supports coordinator can help you apply. Usually if you get SSI, if you're eligible for that, Medicaid comes with that. Sometimes you have to do a separate application, but it does come with it. If you don't have Medicaid, and there's no other, some people do private pay. They pay for services on their own because they have the income or whatever. If you don't have any money and we consider you eligible for services, after the 4 months, that supports coordinator would have to make some type of request for an exception to continue with services, and it probably would be reevaluated every year, because what would happen is we have to use general funds from Lansing, and they keep shrinking those dollars, so we have to spread them across all different populations served. So
you mentioned a couple times that IQ has to be 70 or lower.
for that to be your primary developmental disability. Some people have multiple disabilities. They have intellectual deficits, they have cerebral palsy, they might have seizures, they might have a whole slew of neurological. But if that's the only thing you have, then typically it's under 70. There is a 5-point margin of error, so if someone has a 75 full scale and they have adaptive testing that shows that they're pretty impaired adaptively, then we can sometimes, if the psychologist will give them that mild intellectual deficits, then they could qualify, but there's only like a 5-point margin for that.
Question, so are you saying that you must have an IQ in that range, or that is one of the main criteria, but you could have a higher IQ, but in fact, you could have other qualifying items. You
Right,
wouldn't-
like the
Okay, so you could have IQ of 90,
ASD, yeah.
but if you have other, you qualify under.
Yeah, ASD and cerebral palsy, that's totally debilitating, yeah, and you have had it, you know, most of your life, you've been pretty significantly impaired from your cerebral palsy, then yeah, you may qualify. Yes.
Do you find that the information that you provided, like doctor's reports, school records, if your child is already on SSI and Medicaid, do you find that the information you use to obtain that usually is enough to qualify through your agency, or not necessarily?
The problem is every agency has their, or every system has their own eligibility criteria. Some people that are considered like cognitively impaired in the school system, when we look at their records, you know, they have low average IQ, they have a high borderline IQ. It doesn't always match or mesh with our criteria. Social Security, you know, people get Social Security, SSI for different types of disabilities. As a child, I mean, I've seen a lot of ADHD, I mean, if it's pretty significant. So we do try to get records from Social Security, usually as a last resort though, because they charge us a lot of money to get their record. So that always doesn't match our criteria, but there are people that we say are eligible and they keep getting rejected from SSI, so it's not always a perfect match, but if someone is moderately impaired, you know, has always been Down syndrome, you know, usually those folks have some significant impairments in functionality, so there are people that, you know, are not that complicated in terms of determining eligibility. It's when you get to the higher functioning individuals, and that young age group, the adults that are like 18 to 20, early 20s, that is an age group where everybody is struggling. I mean, I have a child, they don't all have the independent living skills at that age. They don't have those higher level skills, economic self-sufficiency. They're still relying on mom and dad for, you know, so when we see that, it's very hard, and sometimes we deny people that maybe just have those real higher level issues and are functioning pretty well, but you can come back. You can come back at any time and request another assessment. Say that person reaches age 26 and they're still having great difficulty. They're not able to find a job. They've, you know, socially they're not making friends, and they continue to show that these impairments are more significant than what maybe it looked like at 18 compared to everybody else. We're comparing you to the peers, you know, and an 18-year-old is not all that swift in those areas yet, you know. So we, you know, that's what really is hard, is that age group when they're pretty high functioning. So do come back if the needs change, if supports change, you know, if you had a mom that was always providing the major support and they get sick or whatever and they're not able to support that person, if things change, you can always come back and ask for another assessment. If you are denied, you can appeal that decision. If we're not referring you to anything else, you can be given a second opinion, so somebody else will look at that person and determine whether they meet eligibility. And there's all timelines for that, but that information will be given to you if you are denied services. So, you know, don't feel like it's the end of the road if you are. Just, you know, either appeal or come back next year, you know, or whatever. And just keep calling and seeing if there's any other services out there that might benefit the person.
Just a point of clarity. So a supports coordinator would help you develop the qualifying information under these criteria. Is that correct? Or do you first have to kind of give a first blush before you assign a supports coordinator?
Right. It's the eligibility is determined at the Access Center, Network 180 Access Center. It's our little glimpse in time. You know, we meet you once or whatever, and you know, we get all the information. Some folks come in, the parents are, you know, want to be positive and talk about how, you know, all the skills this person has. That might be a time when you want to talk more about needs that the person has, so that those kind of rise to the surface. We have, you know, parents are proud of what they've accomplished, but you know, we can, the person that's applying should know that we just want to talk about some of the things that you might need a little support on. just so that it can be disclosed in that session. Otherwise, if we don't get that information, we can't with clarity say, oh yeah, that area is an impairment, if we haven't gotten the information to support that. And we look for it in those reports that we try to get, but they're.
Is that meeting though in front of the child?
Usually it's with the person, and they can bring you in with them, or if you want to
When
be.
you were talking about all the needs and not the positive and all the needs, are they going to be sitting there and listening to it?
In most cases they are. You can ask your loved one if they wouldn't mind you talking a little bit, and they could wait for us or whatever. If you don't feel comfortable, or you could call after the appointment when they're not around and say, I didn't want to disclose this, but we really have to help him with this or whatever. He's not. You could do it in different ways if you needed to. I try to say, that we're, this might make you a little uncomfortable, but we have to see if you need some supports, and this is the only way you're going to get them if we put them out here on the table. Otherwise, it'll be a big mystery out there.
So we can give you the information without the child there.
If you wanted, and be clear that that's what you want to do. When you're talking to the person, you're setting up an appointment, just say, I'm real uncomfortable with, sharing some significant concerns or whatever.
So is the access provider consultation, is that different from trying to access the Center for Autism? Because I did that several years ago.
Okay, so the Center for Autism is a Hope Network program, and we typically work with people with private insurances like Blue Cross and Priority Health. We do some limited work with mental health and with Network 180 and Medicaid consumers as well. But so yeah, Network 180 is separate from us. Yeah.
Okay, because at the time I went, I think she was only either 14 or 15, and because she wasn't in a crisis, they said, well, we can't help you. I go, well, my doctor told me that, Dr. Rismeyer told me to try to Center for Autism when I come here.
The Center for Autism wasn't open 4 years ago, but I'm happy to talk to you about that afterwards.
It was right after, I know it was newly open.
Okay, I'm happy to talk to you about that afterwards.
Okay.
Yeah.
I didn't know if this was the same thing, because they didn't want her to be at that first consultation. That's why I was kind of surprised. All right.
Okay. And it is complicated in this county with all the different providers. Hope Network has a contract with us to do developmental disability services for adults, like the supports coordination. They do the skill building. They do supported employment. But they have a lot of other divisions or branches. Autism Center's separate. They work in other counties and do things. We only have that contract for those specific services with them. Yes.
Your 7 areas, I'm clarifying here for my information. It's gained largely through records that we already have, as well as interview.
Right.
And if a child is 22 or older, that child has to be present, I would think.
And 18 and everyone has to be present. Even a child that's presenting for services would need to be.
Because we just went through a lot of this with SSI, and it was painful to go through.
Sure.
My son hasn't said a whole lot, but I can tell he's gotten very quiet about things.
Yeah.
To sit through this again is going to be hard on him.
And, if he chooses not to be, we might ask him some general questions, but if he chooses, like, he doesn't want to sit through the whole, he can go and, we have a lobby, there's TV in there, and, if he can stay alone and feels comfortable with that, he can sit there. Or, as I said, you could give some information over the phone that you didn't want to share during the interview. Yes.
Is there, it may be in here, but you listed those 7 criteria which seem to be the key pieces of qualification. Right. Do you have an expanded explanation of what those mean? As an example, self-care means so if you're reading it, then somebody could directionally be getting the right information.
In the mental health code, it gives all those areas, but it doesn't give a descriptive definition. And so what's happened is each county is kind of left to their own subjective how to be consistent. You know, we're trying to be fair. We have it laid out in terms of how we see the areas, and we try to be consistent with how we apply that to everyone that comes through the door. We have a general, I don't have it with me here, but I've got a copy where it just describes some of those, just real basic.
Yeah, that would be, because I think parents are pitching and catching all the time, and one of the big things is what do I need to provide and bring in. I think if there was like a descriptive paragraph that you all use in general terms that you could provide for each one of those, that would be very helpful.
Well, I could certainly give you this. This is just a flow chart kind of thing. It just gives basic, like the ability to complete, for self-care, the ability to complete basic self-care tasks such as bathing, dressing, toileting, eating, personal hygiene without physical assistance or ongoing supervision or prompting from another person. So basically without extraordinary assistance is what that's talking about.
Well, if I could get a copy of that.
Sure. I can. I will send a copy to you, Dr.
Yeah, that'd be wonderful.
And then you can forward.
Thank you.
Sure. Medicaid states that we must ensure efficient and economic service providers. Defines this as the lowest cost of the available alternatives that has documented capacity to meet or exceed the outcome quality specifications. So basically they want low cost but efficient quality services to be delivered. The providers, as I said, we send out requests for proposals. It happens every several years. They have to meet certain criteria. They have to respond to these requests with their proposal, and then we review them, and then we pick the ones that rise to the top. We have certain criteria. There's like a panel of people that review it. We have some community people involved. We had the director of ARC last time, you know, in this review. So we try to get some community involvement. So in addition to them being on the provider panel, they have to collaborate and manage the system with us. So we have lots of meetings where all the providers are represented, and they'll send like their clinical directors or supervisors to the meetings. And so we're all on the same page in terms of service delivery and what the expectations are. These are just some of the providers, the primary providers. Goodwill does the supported employment. I've asterisked the ones that provide supports coordination services, because those are the 4 that you would be referred to. Right now, Hope is not accepting new supports coordination referrals, but they're kind of maxed out. So they're going to be in the picture again though soon. And even if you came in before they were back to receiving referrals, you can change your selection at any time. You choose one of those 4 providers to be your supports coordinator, and then they'll assign you a person. You can change at any time if it's not working for you. I would first suggest to talk to the supervisor of the supports coordinator if it just has to do with personality or whatever. At all of those agencies, I know good people, so they have to adhere to standards that are all the same. They provide mostly the same services. There's a few additional services some people provide. Like Hope has skill building, supported employment. So then there's MOCA, which Hope and Thresholds are a little larger agencies in this county. MOCA and Spectrum Community Services a little smaller, but they also provide services in other counties. Like MOCA stands for Muskegon, Ottawa, Kent, and Allegan. So, you know, their cumulative amount of people that they serve might be the same as some of these other agencies. Spectrum Community Services is not affiliated with Spectrum Health, but it's based, started on the east side of the state, and they have you know, quite a few folks that they serve over there. Real Life Living Services is a new provider, but right now they're only providing community living supports, but they are a provider panel, so you can select them to do your CLS services. And then I put on here a little bit about self-direction, which is the philosophy of self-determination. That means you should be able to direct your services whatever way you choose. If you're eligible for a certain service, like you're eligible for a traditional service, say supported employment, but you didn't want to use your Medicaid dollars for a program like through Goodwill or Hope. You wanted to use those dollars in a creative way through an arrangement that supports self-determination. You have a brother that has a business. He'd take your son, but he doesn't want to train him. He doesn't want to supervise him. If you can find someone to do that, to train, to be the job coach, and follow along and then provide lots of support when needed, you might be able to use those Medicaid dollars in that situation. And in that case, that person that you've hired is going to be providing the service. Again, we'd have to go through that fiscal intermediary, that CPA person, to send out the Medicaid dollars to them. We pay the CPA, they pay your person, and the service can be delivered that way in this creative manner. So there's lots of different creative options that you have. You have more control and responsibility for your mental health services if you choose to do that type of service.
Just a few questions. If you had a brother that would help you, you wouldn't go through all this. Your brother would just help you.
Right, and he would, but if he doesn't want to be the job coach, if he doesn't want to show him the steps to do the job, if he doesn't want to deal with him when he assigns him to another task and he doesn't know how to do it, then you might need someone to be with him to teach him those skills. If your son can do it without that much involvement, then yeah, you don't need us. We don't want you to need us.
How many people do you service a year?
In the DD world, we service about 1,700 or so.
And do you follow do you audit like a success rate? Like say you've tried this and you've tried this and then, oh, we've given you all the services we can, we don't know why you still can't work, that's all we can do. Do you have like a assessment?
We have assessments, we have goals, they're supposed to be making progress on their goals. You have to have clinical justification as to why you're continuing with that same goal or you're continuing that same service at the same level of intensity. There are audits that take place regularly through DCH, through Network 180. There might be cases that are flagged that say this person's been working on the same goal. They're not making any progress. Our goal is for them to make progress, to need less community living support, hopefully, and go from more intensive service to least restrictive service. You want to see that happen.
So is there a point where Medicaid just says, oh, we're done, you've used your money, and that's it?
The only time they would do that is if you no longer meet criteria for a person being a developmental disability. We have service specifications for each type of service. You wouldn't want to put someone in skill building that doesn't meet that level. Maybe they have better skills than that, and they've got all their pre-voc skills. They should be in supported employment. They would flag things like that. Sometimes we have to set caps on units that they can receive, like at certain programs, just because the money has to be stretched amongst all the people we serve. We keep getting new folks. We have to be able to be fair and just with that, how the services are delivered. People need to get equitable. I know there's higher need, and so their dollars are going to be higher, but we do have to have a way to serve the population that exists in this county, so it has to be stretched across.
1,700 is really not a very large number considering the population of Kent County, right? There must be a lot of people out there who...
Those are adults. Usually it's less than 2,000. It kind of goes a little bit up and down.
Yeah.
We have the largest budget, though. You're talking more than 49 million. And we have the largest budget at Network 180 because the services are so costly. And the MI side, they might serve 10,000 people, but our budget is higher because the services are pretty intensive and costly.
Do you keep any statistics, how many people you accept versus how many applied? Like you turn down half the people or a quarter of the people, or? Because if you serve 1,700, you've got more applications than that, I'm sure. Those are just people you accepted, right? So would you know how many actually applied?
There's, that waxes and wanes in terms of, because some people leave the county, there are people that are discharging, either, they leave the county, we have some really elderly folks now, and they may pass, so we're not serving them. We don't deny a huge amount. I mean, there might be 3, or on average, I see about 3 or 4 a month, and there's only about 20 or so, 23 last month, I think, intakes we actually do on the DD side for adults. So there's not a huge volume coming through. And we want to be responsive to when people first call. Before, we used to make you send us all the stuff first and then kind of look at it and then call you to schedule it. Now we want to just hear you and what your referral needs are, and then we schedule you. So you'll call, we'll schedule, and we'll try to get all that stuff on the back end, documentation, but we still have to meet our guidelines or our indicators for Department of Community Health. We right now have a little pilot that we're doing so that people that come through and somehow we can't get all that documentation, but they look like they probably are developmentally disabled, and I give them to one of my staff who, we call it like supports coordination, like if you needed help with a Medicaid application, she could help you with little things right in the front. But what her main responsibility is to get that documentation so that we can say yay for this person. And it helps us extend that timeline. And then once, if it goes through and you're eligible, then we would give you the choice then of your providers that you want for supports coordinating. So we're trying to do all that so that we're not just rejecting people out front. If it really, they present like they have to do, we just can't get our hands on anything. So then we try to do it that way. But, we are responding to all the calls we get. So either people aren't hearing or they're getting enough supports out there that, or they don't know about us, but we do a lot of presentations. So.
Isn't it important to remind the parents that don't give up if you don't get accepted the first time? Denial doesn't mean that it's a denial forever, that there's a chance of getting in at a later date.
If they have that strong part of the, first part of that definition of physical mental disorder, if they have a strong disorder there, and it's just their functionality, you might have done a bang-up job and they've got all the skills they need, but as they get older, then you kind of see that they really aren't matching their brother who at that age was doing this, then you can come and present. My hope is that we keep getting maybe some different kind of services that they might be eligible for.
Okay.
The definition, for autism spectrum disorder is changing. The DSM-5 is a diagnostic statistical manual, is changing that definition. And so that might be coming out here in the spring. So we'll have to see how that all affects it. It's more based on, the intensity, the need, and just one category, autism spectrum disorder. So you're either going to have low need or higher need. And some of those, those diagnoses like Asperger's and PDD are going to go away. So we'll have to see how that all shakes out in the end.
Will that be defined by the state when they interpret the new regulations or the new definition?
They're going to have to give us some guidelines because they're the ones that are funding the service, and up to now they've said that those diagnoses may qualify depending on their functionality. So we're going to have to look to them for some direction too.
Okay.
May I ask that let's let the speaker finish?
Sure.
Yeah, and there'll be time for more questions afterwards.
Okay. I just put a little thing in here about transition students. So if you have an adult child, daughter, son, and they're finishing up with school, or they're going to go through their transition program in school and they're 18, mental health services may be available to them even at 18. Some of the things, though, that would not be available would be the supported employment, skill building, and life skills. Because again, the Medicaid looks at The education system is responsible for that vocational training, functional training, and if they're entitled to it and they're still eligible, they should be getting that through the school. The same with MRS. If someone is high enough functioning to be eligible for MRS services, we want them to explore that first. What happens for us is someone might go through MRS, didn't contact us or anything, maybe they're 23, they stopped going to school at whatever point, and MRS gives us referrals sometimes. They'll say this person, they have like a goal of, for 90 days they have to be able to be competitively employed without supports, something like that, they have a goal. So if that person cannot meet that, then they'll refer them to us, and then we'll take a look at them. But we want them to explore those services first because they are an option for them in the vocational world. But all other services might be available to the student, like supports coordination, community living supports, respite. It all depend if they're eligible and they show medical necessity for that. So contact Network 180, even if your person isn't out of school yet and you think that they would benefit or they have needs or you have needs, you're providing lots of care and you need a break once in a while, you might be eligible for respite services for that person. Yeah. So we want spring to come.